Hello, I'm David Redwine. It's an honor to be speaking to you at the IVF Worldwide online meeting. I'm going to be talking about the origin of endometriosis and its history. The first descriptions of endometriosis was a syndromic benign condition that was chronic in younger females. The symptoms included infertility, painful intercourse, severe non-menstrual pelvic pain, which increased with the menstrual flow, also irritable bowel and low back pain. Signs included uterine retroversion, cervical stenosis, and vaginal nodularity, some with low-grade fever, abdominal bloating. The cause was thought to be due to menstrual retention, and this syndrome was first described by Hippocrates himself. Candidate theories of origin, you've seen them. We'll talk about them. You know about reflux menstruation. It's been long held that endometrium reflux is out the end of the fallopian tube where it adheres to the peritoneum, that thereafter proliferates and invades to become the autotransplant disease that we call endometriosis. And since this occurs every month, the disease is incurable and hormone therapy or even castration may be recommended. And this process of reflux menstruation is supposed to be occurring by the billions. Reflux menstruation predicts dandelion spread of endometriosis. Each month, the more and more of the menstrual flow comes out, with more of the regurgitated particles coming to lie on the pelvic surfaces to become endometriosis. And so the pelvis should fill up like a dandelion field from menstrual reflux. For geographically spreading diseases, older age groups have more. Examples include coronary artery disease, obesity, and facial wrinkles. So the older age groups with endometriosis have more disease than younger age groups. That's the question. Well, reflux menstruation predicts this. And when I went through pelvic mapping of patients with untreated endometriosis, this is what I saw with advancing age. The frequency of involvement of each of these areas seems to decrease with age. Philippe Konig's found the same thing. Recurrence, well, if you excise the endometriosis, it'll just come back, right? So that everybody has it. Well, the cumulative persistence or recurrence rate among patients undergoing excision is only about 19% after 4 years. The mean number of pelvic areas involved at reoperation, well, reflux menstruation would predict that they go up, but actually to be somewhat of a random pattern between 1 and 3 pelvic areas of involvement. We can also talk about published cure rates as judged among reoperated patients without routine post-op medical therapy. 66% were stated to be cured by laparotomy excision, and laparoscopic excision between 57 and 100% cure rate as judged by reoperation laparoscopy. Well, what about the peritoneal circulation arm of Sampson's theory? It's supposed to explain the higher frequency of left uterosacral ligament disease versus right uterosacral ligament disease. And the big feature here is a sigmoid colon, because the peritoneal circulation as it occurs, the sigmoid colon kind of protects this left lower quadrant so that the menstrual flow as it comes out, the seeds of fertile soil can land in this sheltered area. And so this is supposed to explain higher incidence of left uterosacral ligament endometriosis versus right, because over here on the right side, the cells that are reflux are just swept away. And the evidence for this came from a publication by Myers, who was a radiologist. He had 20 male patients with a cancer, abdominal ascites, effusions, abscesses, and then took x-ray as the tilt table was moved around. And this produced this diagram that shows the general lines of where fluid goes. It kind of goes everywhere, follows these arrow patterns that he drew. Okay, well, here is his Myers original figure. Several years ago, there was a publication which showed that if you took Myers' original figure and made 8 individual changes to it, erasing any arrows that are tending to go counterclockwise and replacing them with arrows going clockwise, then you can drum up support for a peritoneal circulation that goes in a clockwise manner as postulated. Well, basically, this is fabricated cartoon science. However, depending on how you redraw and erase arrows, I can show that the circulation is completely counterclockwise. There still remain 2 missing steps of Sampson's theory: peritoneal attachment and proliferation and invasion. Where is the robust microscopic proof of each step? It's been 100 years. This is a hydrogen atom. This photograph is of a hydrogen atom. It's not cartoon science. It's a real photograph. Where are the easily obtainable photomicrographs of the macro occurrences of attachment, proliferation, and invasion of reflux endometrium to support Sampson's theory after all these years? Well, I found the missing steps. You see, what happens is Tinkerbell comes in and she puts the endometrial cell on the surface, and then Tinkerbell flies underneath the peritoneum and drags the endometriosis into the body. Where are the photomicrographs? You can't photograph Tinkerbell. Well, reflux menstruation is supported only by cartoon proof, even at this point. Is it a valid theory, or is it our excuse for ineffective therapy on generations of patients? It makes this the most dangerous theory in the history of medicine ever. So I think we can eliminate that as a candidate theory of origin. Lymphatic spread, well, it's rare. It's associated with colon nodules. There's no defined resultant disease that occurs from endometriosis in lymph nodes. And there's another explanation that's possible. So we can mark that off. Hematogenous spread. Well, how do endometrial cells get through the uterine veins and the vena cava into the right ventricle and into the lung, where it's a high density filtration system, then back out of the lung to the heart, and then out to the kidneys, another high density filtration system? There should be a sky high incidence of pulmonary and renal endometriosis, just dependent on blood flow to those areas. Why would the pelvis be preferentially involved? Where's Waldo? Where's the endo? I don't see it. And so we can eliminate hematogenous spread for those reasons. So we're left with an embryonic origin of endometriosis. Well, actually, all early theories of origin of endometriosis were embryonic. In 1882, it was found within a fibroid, and Babs thought it might be due to embryonic rest. Von Recklinghausen identified patterns of deep endometriosis in places where muscle tissue is present. In 1900, Opitz talked about Mullerian mesoblastic threads, which grow into the connective tissue of the pelvis during embryogenesis, resulting in endometriosis. Recall that there are three embryonic layers. The ectoderm forms the skin and the central nervous system. The endoderm forms the GI and GU mucosa, and the mesoderm forms everything else. So Opitz mesoblast basically is early developing mesoderm. In 1908, Klage applied Opitz theory to deep endometriosis, and there things sat. We had an embryonic origin without plausible genetic evidence. Meanwhile, in the 1920s, a theory of origin based on cartoons was advanced. In the 1930s, radiation therapy was used to destroy ovaries. In the 1940s, Joe Meggs said you could cure endometriosis by excision. In the 1950s, color TVs came into being. In the 1960s, endometriosis was treated with birth control pills. In the 1970s, it was treated with electrocoagulation. In the 1980s with danazol. In the 1980s also was the decade I published my theory of origin, Mulleriosis. The 1990s brought laser vaporization, which sometimes fails to destroy even superficial endometriosis. It also brought us Lupron, which can hinder ovarian function in 20 to 40% of young patients who take it. The 2000s brought us the robot, which showed that the same surgeries can be done more expensively and more slowly. And then finally in the 2000 teens, Oralissa shows that all of the hormonal therapies of the past, if repackaged, can sell a new product. But wait, by the late 20-teens, the wait was over, because the genetic basis of the embryonic origin of endometriosis is being unraveled by genome-wide association studies of single nucleotide polymorphisms. When you look at the signals that have been identified so far, embryonic development, estrogen response, angiogenesis, gene silencer, Hox genes, FSH beta, the mechanism of Opitz mesoblast origin is clear. There's a genetic load at conception, and during gastrulation, the epiblast converts cells to the mesoderm. And here is a video of the epiblast falling through the primitive groove to become mesoderm in between the two outer plates of the embryonic trilaminar structure. So endometriosis is mesodermal tissue. All reported sites of occurrence are mesodermal. This is what gastrulation looks like. The yellow cells would be the internal organs of the chicken. You can almost imagine that little bits and pieces of genetically targeted material got left behind This is a simple diagram that I drew in 1988 to show my concept of abnormal differentiation and migration of cells forming endometriosis. As the gonad cells gather together to form the gonads, endometrial cells that are supposed to be coming to lie inside the uterine tissue cells, they are found outside the area and they're kind of left behind in some places, and this results in embryologically patterned tissue tracts of two types. One is endometriosis, the other is surrounding metaplasia-capable stem cells. Hox patterns in the human female pelvis. Well, the most important Hox pattern is Hox10 because that's the one that signals for endometriosis. Endometriosis has been studied extensively. We have done every sort of test on it, but it seems like that despite the massive amount of detailed subcellular information, we're missing the forest for the pine needles. Endometriosis doesn't exist alone. It exists with endosalpingiosis, they're related. Endocervicosis, it's related too as another epithelial component. What about the muscular components? Adenomyosis and fibroids, they themselves are related and are also related to endometriosis. Structural defects that have been identified associated with endometriosis have to be factored in. The occurrence in males has to be factored in. When you do all of this, you wonder if there is some kind of a Mulleriosis gene ensemble that is at play here that explains many of the related pathologies that we see. Well, if so, what would that look like? Well, it would be part of the human genome, and then there'd be everything else. And then there is a basket of genes that can be populated in here. I just kind of keep my eyes out and look for new ones. These genes result in abnormal differentiation and migration of mesoterm during gastrulation, which leads to all of these tissue and structural defects that we've been talking about, as well as ovulation defects, endometriosis in males, other mesothelial rests, etc. For each of those situations, the anatomic location, morphology, histology, symptom activity, malignant potential can vary from none to severe. But humans have only been around for about 65,000 years. Look at all the splits from the human clade of primates that develop endometriosis. 340 million years ago, the first mammal appeared, and 500 million years ago, the first Hox genes appeared. That means that sometime around that time, Hox10 shot an arrow through several primate clades down to our own human species. But what came before that? Well, that was only 500 million years ago. Before that was Precambrian, and things were pretty bleak. The oldest animal fossils, 1.7 billion years ago, eukaryotes, 2 billion years ago, transitioned to an oxygen atmosphere. 3.6 billion years ago, the oldest rocks formed. Greater than 4 billion years ago, life on Earth was impossible during the Hadean era. And before that, it came from stars and the cosmic microwave background. Everything was patterned long ago in utero. Embryogenesis proceeds down the posterior coelomic cavity. And during that coelomic migration, there's epithelial ingrowth of the coelomic cells into the substance beneath them. This results in a gradient of tissue activity, which is genetically determined. The tissue can be superficial or deep, and it can contain two types of tissue: rests of actual endometriosis or stem cells, which are associated in gradients. The result is repetitive, familiar macro and micro patterns of endometriosis, which are largely genetically determined. The most familiar macro pattern is the order of frequency of involvement of the pelvis by endometriosis, with the posterior pelvis being most common and uterosacral ligaments being involved by deep infiltrating endometriosis in some cases. Macro patterns of intestinal endometriosis, everybody's aware of obliteration of the cul-de-sac with or without a sigmoid nodule. The invasive disease of the uterosacral ligaments can sometimes go into the adjacent ureter. If you see a rounded rectum, that usually means there's muscularis involvement. There's macro patterns of extrapelvic endometriosis, 10 to 1 favoring the right diaphragm over the left diaphragm, which is 10 to 1 for the right inguinal canal to the left inguinal canal. And the right sciatic nerve is involved 2 to 1 over the left sciatic nerve. And even the abdominal wall may have its own pattern tract of tissue which is capable by metaplasia of forming endometriosis, such as with scar endometriosis. There are smaller macro patterns of endometriosis, including the antimesenteric side of the bowel, and the antemesosalpingeal side of the tube. Posterior pelvis is the most common area of involvement because that's the pathway of organogenesis. And fibromuscular metaplasia of deep endometriosis occurs in the muscular structures in von Recklinghausen's pattern. Another macro pattern is widespread superficial peritoneal disease. One type of micropattern is hidden endometriosis in the muscularis of the bowel. The reason endometriosis does not involve the colonic mucosa is because the colonic mucosa comes from the endoderm layer. Micropattern 2 is hidden seeding deep inside the ovary. Russell found an area of endometriosis, which can lead to recurrent ovarian endometrioma cysts. The third hidden micropattern is seeding of lymph nodes, and that's nearby nodular endometriosis. Surrounding stem cells enable superficial recurrence in some patients following excision. Now here's a schematic. If you look at the superficial endometriosis on the surface, it's surrounded by some stem cells. So superficial recurrence is possible if there are some remaining stem cells. But if you take the excision even wider to an area of no stem cells, you're more likely to get a local cure. And the same thing can basically be said for deep endometriosis. So superficial recurrence after excision explained by this type of model. My personal path to an embryonic origin was fairly short. Once I realized that older age groups don't have more areas of disease and that age-related evolution and color appearance can give the false impression of geographic spread, I realized that Sampson must be wrong and an embryonic origin of pattern tracks seemed more rational. Therefore, endometriosis could be cured by removal of those tracks, and I have a publication to support each of those premises. It's important to remember no medicine eradicates endometriosis. Sushruta said that surgery was the highest of the medical tantras because it could produce instantaneous results. And Hippocrates said that the diseases which medicines cannot cure, excision cures. This means that excision is true Hippocratic medicine. Joe Meggs said in the 1950s that endometriosis is curable by conservative excision at laparotomy, and that's been found to be true today. It's not a random disease. It follows genetically dictated patterns. So if you remove the patterns, you potentially can cure the patient. What we're seeing is convergence on an embryonic and therefore genetic origin of endometriosis. Different authorities have arrived at that conclusion from different directions during different centuries. The genetic control of embryogenesis is being investigated, and all embryonic theories will be validated. They all have the same mechanism, that being genetics plus basic embryology. Here's a partial list of those that are beginning to favor a genetic and therefore embryonic origin. I was the first to look for evidence of an embryonic origin by histology, I believe. Reflux menstruation predicts the failure of all therapies because it'll just come back each month with reflux menstruation. This creates an unholy symbiosis of medical therapy and incomplete surgery provide the failure that's predicted by reflux menstruation. Thus, there's this circular proof of the theory and of incurability. Because of all the women who have been treated and mistreated on the basis of this theory, that makes it the most dangerous theory in the history of medicine ever. Reflux menstruation is not needed. An embryonic origin, such as Opitz explained, satisfies everything. What do we need in the future? We need to abandon reflux menstruation as the origin of any form of endometriosis. We also need more excisional surgery, which is true Hippocratic medicine. Surgery will augment genetic research. We need to do more genomics and proteinomics and any other omics on tissue removed from the pelvis in site-specific areas. We also need to find out what endometriosis secretes. So we need to stick some micropipettes into some glands and see what that's going on. A new scientific truth does not triumph by convincing its opponents, but rather because its opponents eventually die. So we need new cemeteries. Opitz was right, Sampson was wrong. Thank you. Well, I hope you enjoyed the talk. It's been my pleasure to speak to you. I hope I've convinced you that it's the embryo going forward from here. Thank you for listening. Goodbye.